from Madrid, Spain. Both of them have published extensively in this area and had seminal papers from Europe and the US. Our presenters are Kate Gurney from University of Washington, Seattle, who will present the first case. The second case will be our graduating chip fellow from Emory, Brian Kindia, who presented a case of In-Stent restenosis that he did with Bill Nicholson, who unfortunately could not be here today. Our chat moderator is John Lisco. Our support is Laura Porter and Brian Peterson with SCAI. So without much ado, I'll get started on this case. It should be noted that we are supported by an unrestricted grant from Medtronic. Next. And you can earn both MOC and ABI points through this, as well as CME points. And there's a little slide at the end of this. Now, Kate and everybody else has disclosure just disclosed here. And these how you get to the My Courses portion on SCAI, where you can get credit for this 1 hour's presentation, both CME and MOC. So I'll get Ron to moderate and be the moderator for this session and start the first case will be presented by Kate Kearney. Thank you.
Thank you very much for having us. We are glad to be this part of SCAI webinar. And without further ado, Kathleen Kearney has a very interesting In-Stent restenosis case in bifurcation. Take it from here.
Okay, sounds good. Thanks so much for having me. It's a great group of experts. I'm actually really looking forward to some input. This is a case from a few years ago that I think I would do differently now, but I think there's lots of ways to attack this. Is it the screen showing up okay? Can you guys see my slides in a...
It's coming. Not
okay.
Quite.
Yeah, it says screen sharing was paused. We jinxed it. Okay, I'll try that again.
Yeah, maybe there you go. Unshare and try again.
Yeah.
Yes. Fantastic. Go to the full presentation.
Okay. Yeah, when I'm plugged into power here. Can you guys see that okay?
We prefer the full presentation.
Oh yeah, you're still getting that one. Okay, I'll unplug here. That should work. We jinxed it. I said it would be fine. Okay.
We go.
Perfect. Thank you. Sorry for the hold up. So this is a gentleman who presented after bifurcation PCI and had recurrent ISR. His initial presentation was interesting in that he was out playing golf. He really hadn't had a lot of anginal symptoms. And basically he recalled bending down, picking up a ball, stood up, and then effectively passed out about 30 seconds later. No prodrome, just had some chest pain at that time. And was resuscitated quickly, but medics came to the scene, basically high suspicion for aborted sudden cardiac event. Lots of salvos of ET when he first got picked up, but nothing sustained at that point. So his neurostatus was intact, he was hemodynamically stable, and he was found to have ISR and was transferred to us for further intervention. So for this gentleman, you can see here, he's got basically a focal area that looks quite severe leading into this bifurcation of an OM. His RCA looked fine. He has a prior LED stent that's patent. And so this was really felt to be the culprit. We didn't have a lot of information about how the bifurcation had evolved over time. It sounds like he had initial stenting into an OM and then had repeat stenting for ISR the following year. And that was in 2014. This was a couple of years ago. So several years in between that had gone well. With initial ballooning, you can see we do have some trouble here in the lower limb though, and there's a significant waste effectively right at the bifurcation. Upper limb was expanding better at that point. So a few other details here, just mentioning his prior PCI, as we had founded that at least 2 layers of stent at some point is what was described in the notes. His initial troponin came back at about 0.5 and a repeat was still less than 1, it was in the 0.8 range. So not really a rip-roaring sign that he had thrombosed, and of course had flow here at the onset. At this time, we were using the 30 megahertz IVUS. So that's the image here of the upper branch, which we were able to deliver into. Just come back so you guys can see that. So distally, we've got a stented portion there and a pullback through the upper branch through the bifurcation. Overall, not as much calcium as I was expecting necessarily on the outset. Slightly small stent, but certainly has some in that bifurcation area. Having moved to an HD system now, I sort of recognize some of the issues we had trying to get the image with the pullback so you're not popping in and out. So I think that's one thought there. But maybe I'll pause. We have such an expert panel. I'm interested to see what people would think at this phase. We did additional ballooning to the lower branch, but we're unable to IVUS that at that point. Things I was thinking just to throw out were we were concerned that there was stent deformation in the lower branch, that the stent from the upper branch might have some impact on that. We were also struggling with several balloons rupturing when we were deploying those in the lower branch segment there. So based on this, I'm curious if there's any thoughts from the panel. Let me start with you, Ron.
Yeah, so one word of clarification, the IVUS imaging was done after the intervening with the balloon or before you intervene with balloon?
Yeah, afterwards. We weren't able to deliver those at this point of volcano IVUS, but we weren't able to deliver that until we had taken a 3.0 balloon down both limbs. And at that point, we're only able to deliver to the upper limb, which
The
is
balloon.
sorry, balloon delivered to both. We had a waist in the lower branch. IVUS was just to the upper branch there.
Yeah, so we see here both the under expansion and we see also tissue. I mean, again, it's hard to appreciate the exactly degree of tissue because it was already ballooned before.
Mm-hmm.
But I'm going to ask the question first to Fernando Alfonso. How much it's important for you to know what type of a stenting technique at the bifurcation was done before, whether it was a culat, whether it was a provisional, whether it was a DK crash or mini crash. I mean, does that really matter when you deal with a situation like that?
Yeah, thank you, Ron. Thank you for the opportunity to be here in SCAI. Well, we all keep saying in every document the importance of understanding the underlying mechanical problem for in-stent restenosis, but in a bifurcation where you don't know how was exactly the prior strategy, this is key. I mean, we need to understand where the stents are, and this can be rather difficult if we don't have the clinical history, and also we don't have further information. And in this case, it was very interesting to see even that using high pressure, the balloon the balloon wasn't able to rectify the artery. So that I think it's very important to understand where the stents are, because the mechanical problems that can complicate any in-stent restenosis are particularly of concern when there is a bifurcation. You can have a protruding stent, you can have the wire going different places. So it's critical to have a proper understanding of the underlying anatomic substrate.
Thank you. So question to Dr. Sharma. First of all, we have to get opening of the vessel, getting a good result before we apply any other therapy. And we can discuss, I mean, we have POBA, cutting balloon, DES, DCB, brachytherapy. But how do you approach that to get the optimal outcome before you apply the adjunctive therapy to prevent recurrence of the event?
Yeah, no, Ron, actually, that is the crux of this case. And thanks to SCAI and Rob giving me the opportunity. But I would say that clearly what has been done, and in this case, I would say cutting balloon will not help. Now you need to have some other ablative technology. Some people will use a laser because you need to, it looks like, again, very tough to say, but I think it still looks like a mini crush at that level. And particularly if your stent was able to go, balloon was able to go easily on the superior branch, that will speak more so that they did probably a kissing balloon in the end, and but the lower one, inferior branch definitely got deformed. Now, whether it's some unexpansion, various factors, we can't even figure that out. Angiographically, maybe, sometimes if IVUS doesn't go just for the, do the stent boost, that also will give some idea. But here we need to do something. And I think the two technique which will help here is the rotational atherectomy with a very small burr, with a 1.25 or 1.5, particularly 1.25, knowing that it will be a very tough, a very small lumen, or laser. So one of those two things have to be done in order to go to the next level. And next level will be that how else can you improve the lumen of the lower branch?
Yeah, so I'll pose another question to you, Dr. Sharma. You mentioned rotablator. A lot of people would be concerned that the bear would be trapped, and this is already seems to be mechanical issue. We're not sure, maybe it was a culat, you say it's a DK crash, but what are the concern? Even a smaller bear could be trapped. You're basically in a territory of a lot of metal there.
Yeah, no, that is, I would say this is kind of case I'm doing. I'm actually predicting the bird is going to trap. There's no question. Very likely, and many times when these kind of cases we did, and I tell my associate or fellows, I say, you know what, we are doing very carefully, we'll go very slow, lower speed, would not push it, but bird is going to trap. But most of the time, even the bird traps, you can really pull it out. Now, can you do orbital atherectomy, which has a ablation on both the sides? And I can tell you my personal experience of the unexpanded stent, orbital atherectomy, I tried probably 15, maybe worked in 1. So orbital does not work. Clearly, why orbital doesn't make it heat? Why the rotablation work? Not because of ablation, it just heats up the metal. And orbital doesn't heat up, so the orbital does not work in this situation. I would say the way it looks, and knowing that if we have laser available, even my first choice will be laser. Laser may not go, but I know 1.25 bar can go with a chance that it can get stuck. That's no question on that one. With this angulation, as Ron, you pointed out, it's very likely even your small bar, 1.5, some people believe 1.25 get more stuck than 1.5. So whichever one, the very likely the bar is going to stuck in this case. But most of the time, we can pull that bar out by pulling the wire, which is very strong. But rare cases may give you trouble. Then you have to do a Godzilla and other things. But yes, something need to be done to open the inferior branch, which is also good size, equal size branches.
So, Dr. Alfonso, in Europe, you don't use much rotablator at all. I doubt if you use laser. In a situation like that, if you want to keep it simple, what would be your approach? Now you have the imaging. Again, we still don't know what was the original technique, but you see you have a mechanical issue, you have tissue issue, and you have under expansion. What's going to be your approach, first of all, to optimize the outcome?
So just for the sake of discussion, we try to avoid rotablation and also laser in most cases with in-stent restenosis, unless there is clear case of a really undilatable stent. I mean, if we can see a waist which is impossible to dilate, then in those cases that are very rare, we go for these debulking devices or ablative devices. Nowadays, we try to go, in this case, the branches are not very big, so that we will go perhaps with a small balloon, perhaps a 2-0 balloon, and try to, if this is not working, I will go with a high pressure balloon. And now most people in Europe is jumping very quickly to lithotripsy, because I think it's safer, it's very easier to use, and in many cases you got a very good expansion of the stent. Until now, we had very little data on the use of lithotripsy in patients with in-stent restenosis, but now we got plenty of observational study, and I think when there is clear under expansion that you cannot cope, you cannot address with a high pressure balloon, we will go for lithotripsy rather than use a laser, or rather to use rotational atherectomy, especially in these vessels and especially in a bifurcation. That would be my bias.
But Alfonso, the lithotripsy will not make a first turn. They put a balloon very difficulty. They went 3-0 balloon 20+ atmosphere, and nothing happened. So we know that IVL will not make the turn. Now, only question is open and see, which is just came to America. I know Kathleen said this case was done a few years ago. You might decide might go, but definitely, I mean, this kind of angulated were so difficult. Your IVS didn't go. Balloon went, but could not crack. They went 20-22 atmosphere. Other could be maybe 2.75 or 2.5 or 3.0. But you cross the lesion, but go very 8 millimeter focus balloon and go 24-28 atmosphere, or existing non-compliant balloon. Maybe a short might be, but key is that in this case, lithotripsy IVL catheter will not make a turn.
Yeah, so I actually think that open and see is a good option if it can cross, because you can take it to 35 atmosphere. My view is probably, first of all, let's try to do a good balloon job, because I'm not sure that the balloon was optimized. This was done mainly to restore flow, to do the first shot, to facilitate an imaging, but I don't think you're done with balloon work here. So, Kathleen, you want to tell us what did you do at this stage? You heard all the options here. I don't think we mentioned.
May I interrupt for a second? So, audience, please post your questions in the chat box, because we have chat moderators who will look at your questions and post it to us. Thank you.
Yeah,
Kathleen?
thanks for the input. You hit on a lot of the things we were thinking at the time, and certainly I think with the armamentarium of OPN balloons, which we just received, as well as lithotripsy, actually come into play a little bit later in this case for him as well. Based on what we had and some difficulty with the expansion, I think those are good points about shorter balloon. We tried an 8mm balloon, which tended a watermelon seed. It was kind of hard to bridge there, but seemed like we made a little headway. Went back with the longer balloon. You can very clearly see the waist there. Sometimes I found with the long balloons that they will almost straighten that area and crack the calcium. So I'll try both if the short balloon doesn't work. Obviously, you'll take whatever you can get in those cases. But here we went ahead and did a little more ballooning to try to facilitate passing laser. Took the 0.9 laser catheter down, did Potentia on contrast, and did that in both limbs just to try to see if we could modify that. I think for all the points that were mentioned, I was a little concerned about getting a burr trapped in him given the acuity of his presentation. On one hand, typically in OM, we can get away with a lot. Patients will tolerate that. We can get it out with a guide extension, et cetera. So certainly, like you said, prepared for burr entrapment. Here, we were a little bit more nervous about doing that. Obviously, we could have had no reflow with laser, but just feeling that using that leading edge of the atherectomy, that maybe that would facilitate better expansion, not too sure what we were dealing with at that point. And based off the other imaging, I was suspicious it was more of a stent problem or fibrosis as opposed that he's got very bulky calcium burden. But of course, we're still not really too sure based on that. So I think can see in both views here that it's really just past the bifurcation there that is still acting up despite that. So we got slightly better results with a couple balloons rupturing, and then effectively got a 3.0 scoring balloon down and got, marginally better results, I'd say there. When brachytherapy came, as I don't know what Ron's team is like, but ours is and Dr. Sharma's, but basically, they're ready to get out by 4 o'clock. So when they came by, we went ahead and treated the upper branch, realizing we might need to bring him back, and really weren't able to ever facilitate much delivery for the lower limb. He was doing it appeared better. And I think, part of the question here is, how, if a surgeon's grafting these, you might even only graft one of those. Is it enough to have a really good result in one branch where our post-ivus looks good and accept a focal issue in the lower? Do we need both, or are we going to maybe compromise one by trying to perfect the other? So quite frankly, I think our setup here, as we're radial, we figured we were a little bit limited. So we elected to stop for today and then come back and plan to do some more work. He actually did have recurrent symptoms at that time and ended up getting admitted and transferred over for that. And somewhat surprising to me here, he does have some ISR actually in the upper branch that I thought we had a better result. You can see this is around the time we switched IVUS system. So this is our imaging here, but again, we're only able to deliver that to the upper branch. I still feel pretty hampered by some assumptions that we're making and some difficulty crossing the lower. At that point, this, looked fairly focal, but is certainly concerning that that's part of the picture. And we were a little bit on the fence with that. We basically, serial balloon inflations, ultimately were able to deliver. At that time, we just had peripheral shockwave. So we were able to deliver a 3.040 to the upper limb, but again, just delivery issues being the main crux for the lower. Had repeated laser atherectomy, we were able to, it actually had more difficulty getting NCs down. Before we had a 3.0 pass, with some difficulty, but fairly easily. Now we're kind of basically barely getting this 2.0 down. And long story short, he had a new area of stenosis and a calcific area of his mid RCA. So had orbital atherectomy and a 4.026 on that side. So basically, kind of similar because he came in on another ad hoc day. I think the team we did a decent job patching him up, but really don't feel satisfied that we've got kind of everything sorted for him and had discussed coming back. He actually felt quite a bit better after this. So we figured, well, maybe that focal area will be okay. He did well for about 1.5 years. And then had recurrent symptoms and comes back with this image. I will say, especially on imaging, we can see he's got some soft plaque in an unstented segment at the proximal circumflex there. So we went ahead and started with physiology of that. The RFR into that upper branch was 0.98, so that didn't appear to be the problem. So I don't know, any thoughts here about, is this worth going after? Would you start by drilling the lower branch at this point? We kind of know delivery issues and optimization there has been poor in the prior cases.
Yeah, you brought a lot of points for the case. I would just mention that the 1.5 years, the area that was radiated seems to be looks fine. And the other comment that I would make on radiation here, that it's very rare to see recurrence of restenosis 3 months after radiation. To me, if it happens, that means you didn't radiate that segment. I don't remember any case that restenosis after 3 months with brachytherapy. Dr. Sharma, any?
Agreed.
But you?
Fully agree, Ron, on that.
Yeah, and I think there was a challenge to deliver any of the systems there. So maybe for the audience, you mentioned a lot about the laser. How do you do laser in in-stent restenosis? What is your prescription? Contrast, no contrast? What is the fluence? Can you tell us a little bit how you do that? Because we want to learn.
Yeah, I think certainly variable somewhat. In training, we did a lot more of larger lasers with potentiated with contrast, but I think our rates of no reflow were quite a bit higher too. So overall, I moved away from that as much. In these cases, when we're really facilitating a underexpanded area or concerned about really calcium modification in particular, usually 0.9 on 80/80 for your fluence and rate, and with small puffs of contrast. And effectively, we'll take just 1 or 2 cc's of contrast in the syringe, so it's mixed with saline, and kind of go from there. From the bench data they get, you don't get a lot of augmentation really once you're over 30-40% contrast mix. So we'll start kind of low there and just try to get some of those cavitary bubbles for that. On imaging, on the other hand, if it's all soft neointimal hyperplasia and we're trying to use more of the photoablative effects, then I usually will upsize the laser and we just go really slow, typically on saline flush, and see. And I think it's one of those things, it feels like voodoo. I'd sort of convinced myself it wasn't doing anything, but when we started re-imaging these cases while we were waiting for the radiation people, sometimes, especially with better imaging like OC for near field things like HD or OCT, we do see some difference there. So it feels like if the minimal area is still poor, usually we've done some ballooning to facilitate getting a good image, then we'll go ahead with that. But I'm curious to hear what others do.
Yeah, you mentioned a lot of things again. I just wanted, first of all, ask a very quick question, Dr. Sharma, about the brachytherapy, and then I'm going to move to Dr. Alfonso to tell us he doesn't have brachytherapy in Europe anymore. So, but first of all, there was a question, should you radiate, if you can, both limbs, or you would radiate only one limb, Dr. Sharma?
Yeah, so question comes is, and again, knowing that the area which you need to radiate, and if you overlap with this kind of bifurcation, maybe are troublesome, and we are done both branches. If the catheter, let's say the lower branch would have opened, so first you do a radiation which was done exactly from top branch, then the second one you'll try to do just after the proximal end at the bifurcation and go further down. So not to put additional radiation in the proximal part of the circumflex. Main circumflex. And yes, we have done bifurcation radiation brachytherapy, maybe like 12 cases, not that common, but yes, idea is that now I still think the most of the data, and of course Ran knows more of the pathobiology about this, and this is a part of the paper when we published in the circulation intervention, is the dose of the radiation which we talk about was done in maybe one stent and the native vessel. Now we have 2 layers of stent. Is the same dose? We are still using the same, sometimes 3 layers. So is it enough to go to the vessel wall, or it is just too little? So that was the editorial also of maybe with the multiple layers of stent, the radiation dose which we do, and I know that our radiation guys don't change it. They don't do it also repeat. The 10 years, they say less than 10 years will not do the repeat brachytherapy. As a patient did so good for 5 years, let's do it. Before it used to be 1 year, 1.5 years, 5 years come back. Let's do it now. Every time used to come 12 months and 18 months. So no, we will do it. Only we can do it. We are doing 2 cases now, which we did in 2012, 2013. So far, who got a second radiation of the same segment, but 10 years later only.
Yeah, no, I agree. I would make one comment on this, and then we'll move to Dr. Alfonso, that the radiation oncologists and the physicists are very, very conservative. But our experience in this case, we probably would radiate both limbs. We'll try to minimize the overlap. and also repeat brachytherapy, my cutoff is 1 year. So if you passed 1 year, I'm okay with doing another dose of radiation because nothing else works. But Dr. Alfonso, you don't have radiation. There was a question from the audience. Give us more options. And I didn't hear drug-coated balloons. So I'm asking you, where is the drug-coated balloon option here?
Well, yes, in Europe, brachytherapy is being abandoned, which we don't miss it. We don't miss it. But in very challenging case, as this one we are discussing, I mean, having all the possibilities, I think is a great advantage. Now, in Europe, we got drug-coating balloons, and this is the typical scenario where these devices are used. I mean, if you review all the documents, I mean, your classification from the SCAI document just published, our state of the art, I just looked for that before this webinar. And if you look for bifurcation, there is no data. There is no data saying or explaining how we should use that, because bifurcations have been classically excluded for all randomized clinical trials. Having said that, in Europe, we try to select drug-coating balloons, and there are some with large experience and large evidence back in the use, small series, but to us, the evidence is good enough to have 1A indication. For us, this is very clear. And even though data in patients with large branches causing bifurcation are not there, this is a beautiful scenario, because when do you want to avoid a second metal layer? When there is a major branch, you don't want to jail with another layer. So in this case, I think in most centers in Europe, we will be using drug-coating balloons in the two arms. But having said that, I mean, the choices are what they are, and even this treatment sometimes fail. So this is what we would do. Prepare the lesion as best as we can. Another interesting case in this, another interesting issue in this case is that there was this waste in the balloon, yet the IVUS, I mean, show some calcium, but wasn't massive calcification. I was expecting to see more calcium, and there was calcium there, but no massive calcification. So important to prepare the lesion, very challenging in this case, and then trying to use, I will use the more classical drug-coating balloon to make sure that all the evidence is backing it.
Thank you, Dr. Alfonso. So I think the question was that, Kathleen, we didn't answer what to do with that lesion beyond that. This is not related to in-stent restenosis bifurcation. So for the sake of time, I'm going to pass it to Dr. Rob. But maybe you want to show us one more thing, Kathleen, before we do that?
Yeah, we'll let you do that, and then John will have some questions.
I think John is, yeah.
So that we can answer
I think what might be helpful is when we finally actually image, we have a lower profile IVUS system at this point, we actually finally image that lower branch. So I think that is helpful. So basically same story, serial ballooning really doesn't look better until we're able to deliver, get better expansion after repeat laser on contrast. And I think this time we just had better guide support. We had an 8 French guide, we used a guide extension, we had to bail on the other wire occasionally, but we were kind of thinking like, well, we're either doing that or we need to rota down here. We've been fussing around multiple times and this is really all that's left. So here's the image on the left of the branch we've seen, the upper branch, not quite as much calcium burden as you might expect. This is now the lower branch here. So we see a small stent. This is, I think before we use the slide very often, so I apologize. We're going back in and out a little bit here on the more focal segment that we'll see momentarily. So coming back to the main branch and then going back in here just before the bifurcation here in an area that is quite small.
John, you have a question from the chat?
Oh, we do. Thanks, Dr. Waxman. And just to everyone on the panel and attendees, there's an open chat where you could post your questions that'll get asked. So one of the attendees asks, in patients with 1 or 2 layers of stent, do you feel compelled to stent if you're going to perform either laser, lithotripsy, or rotational atherectomy months to years out from an intervention?
So this is a third stent, Dr. Sharma. Would you put a third stent there?
No.
Dr. Alfonso?
I would say that the third stent in our lab is like a class 3 indication. So we don't do it. And that's where the brachytherapy comes in. And many times we'll just open with a balloon and bring back, knowing that brachytherapy done in a duration time. And now big problem is, which is now being the Med Alliance, the solution DCB trial, that if you have brachytherapy and comes back, you cannot use a drug-coated balloon. They don't do it in Magic Touch. They don't do it in Solution DS. So I don't know, maybe others, yes, but looks like in brachytherapy, patients have been excluded and they're so disappointed. I had at least 12 patients waiting for drug-coated balloon to come and comes in and boom, first exclusion is if you have a brachytherapy.
Kathleen, any other comments on the case before we move to the next one?
Or show the last one. No, you are able to open now. You put iOS.
Yeah, so I think honestly, I was really fixated that there was some bifurcation issue with metal and worried about that. I think it's really just a focal area of calcium, and the bifurcation.
Circular calcium. There's a full 360-degree calcium in that area.
Yeah, so I think nowadays, if we had shockwave or OPN, that would be a good strategy to try to avoid ROTA if you're worried about burr entrapment. But I think honestly, if we had gone to that for earlier, we probably would have saved him a procedure here in the interim. Ultimately, he's done well. It's now been, we got better expansion, repeat imaging looked better. And I think ultimately this was the final result, but fortunately he's done better. He's coming up on 2 years and he's felt quite well. So hopefully we've knocked that back for a little bit, but I appreciate everyone's input.
But you did the brachytherapy to the lower branch also now.
Yes, we did. So, and I will say our radiation team has sort of reevaluated our dosing strategy and all of that. Their feeling is that with calcium stent and plaque, we're probably not overdosing that area of overlap in the proximal segment by much. So even if we don't deliver it distal enough, they're willing to basically do that. So it is technically kind of his third treatment in that upper area. I think it's a good point that first recurrence was so early. It just is completely out of line with what we normally see with typical ISR. So altogether, he's doing better now. On the flip side, we have a lot of repeat brachy patients. We have not seen vessel injury or issues related to that so far. So I think we've tended to kind of convince them to be a little bit more aggressive there.
In my experience is that the arteries are much more, the stented arteries are much more forgiven than the biology that the physicists and the radiation oncologists are afraid of. So we published that, hundreds of cases, repeat brachytherapy, bifurcation. We have not seen any issues with it, as long as you don't put a new stent. But John, any other questions from the chat?
There is another one, Dr. Waxman. So there's been talk of the OPN balloon, and I don't believe a lot of people are familiar with it. Just the fact that it's a twin layer balloon that allows you to go to super high pressure of 35. And the question is also that anecdotally, has the panel had any experience with it? And from a complication standpoint, has anyone had noticed a higher incidence of perforations going to that high pressure?
So overall, again, our experience is very limited because it was just released. The balloon actually does a very interesting job. So we developed an algorithm to start with a regular or high pressure balloon, because the profile of this balloon is not that great. I mean, it's not like a regular high pressure balloon. So you have to do first a regular high pressure balloon to facilitate this balloon. After that, we're using the open NC. We go up to 35 atmosphere. I know some people in Europe go off label even more than that. The likelihood that this will rupture is not zero, but it's slim. It's not like a very large one. And apparently, interestingly, it doesn't cause a lot of dissection, especially if you are within the stent because of the twin balloon that you go very focal high pressure. Now, if that doesn't work, then the next strategy after that is lithotripsy. So we have one step before we do the lithotripsy, and you're not losing it because after lithotripsy, you may want to do another high pressure balloon. You can still use the open NC. So that is our strategy, but our experience is very limited because it was just released into the market.
We need to move on to the next case. Thank you very much, Kate. So in the next case, in the interest of time, Brian, can you proceed and get started? Thank you.
All right, thank you everybody for having me. It's an honor and a privilege to get to present a case and have a discussion with such an accomplished group. I'm going to share my screen here. You guys see the slides?
Yeah. Yes, we do.
Great. So the case we're discussing today, the background is we have a 68-year-old female with a history of coronary disease with a remote PCI in Iran years ago, and then a somewhat recent PCI at an outside hospital, October of 2022, presented with recurrent heart failure admissions and then unstable angina. For her PCI history, she's got a remote history of a PCI with ×4 in Iran, and then unknown stent sizes and locations from that. And then recently at an outside facility, had a left main to circ stent in October with a 2.5 by 38 on it, a 2.75 by 38 onyx. And then an osteal RCA stent with a 3.5 by 38 onyx. And then relevant history is hypertension, CKD stage 3, and tobacco abuse. She had some cardiac diagnostics done when she got admitted for, I believe, the 3rd time in 3 months with heart failure. TTE performed, showed that an EF was 15% and she had severe MR. We did a right heart cath at the time of our diagnostic angiogram with the numbers shown below that were most notable for, moderate pulmonary hypertension that's post-capillary in the setting of an elevated wedge of 28 and cardiogenic shock with an index by Fick of 1.6. Here's her diagnostic angiogram. So I'll pause here before we get going on what we did next. We stopped at this point on the diagnostic day, admitted her to the heart failure service for optimization and discussion about what we thought was the best plan to approach here. But I'm curious, we got multi-vessel disease, very high risk patient with a low EF, severe MR. How would you approach this? What vessel would you tackle first? What would be your approach in terms of support and no support? I'm just curious what the group's thoughts would be on this.
Dr. Sharma.
Yeah. So the very interesting case, and knowing that probably had 5 or 6 interventions. I'm sure the LED has multi-layer in some area, but entire almost goes up to the apex, becomes subtotal. And with this condition, if Impella is available, I think we'll take a Impella and probably do the RCA proximally first with short segment. The LED will require a lot of work. We will do rotational atherectomy of the LED, such a diffuse disease, using a 1.5 bar. I know there is a question of more slow flow, but otherwise, no matter what you do, you'll not be able to squeeze all the intimal hyperplasia. And that's I would do. We try to do both of them. Although there is a lot of data, people believe is the cardiogenic shock, you do a culprit vessel, but I think it will be very tough to say what the culprit is in this particular case, in this shock situation. There is, although RCA is about 80, 90 proximally short segment, LED is diffuse subtotal. Maybe that may likely is the culprit, but both could be culprit in this particular case, knowing that LED has very little blood flow at present.
Do you have any perfusion study or viability study on that patient before we do the intervention, Brian?
We did not have any MRI viability or anything. She had an echo and it was, diffuse kind of global hypokinesis, but every segment from what we could tell on the echo did look like it was moving to they were all equally hypokinetic. There was no particular akinetic portion, no aneurysm, no LV thrombus. I will say that while she was getting optimized between the diagnostic cath and the intervention, we did get a CTA of the legs because, as you guys pointed out, we were thinking about Impella support. And unfortunately, she had pretty bad iliofemoral disease that was not amenable to an Impella insertion either, unfortunately.
Ron, at your center, you like optimization, and do you use less Impella since you published that paper, or about the same, or do you use more balloon in the situation, or?
We try to use it wisely. We don't have anything against Impella. Impella is a great device, but I think sometimes it's overused, sometimes it's underused. So we just try to use it when it's needed. My issue with this case, frankly, when I look at this LED, if you want to show us back, just go
back,
2 shots backward. It is really look to me like I'm not sure we can really keep that artery open, even if you're going to recanalize it. Look at the distal disease of the vessel. I mean, it's not just in-stent restenosis. There's really nothing going on there. And I can tell you, these are the cases when they send them to me for brachytherapy, I'm actually reluctant to do it because I said, look, if I don't have a good flow distally, the likelihood that this artery will stay open, even with brachytherapy, is not that great. So to me, the most important thing, and that's why I deferred it to Dr. Sharma, show me that you can get a very good flow down the road, because if it's not, and this is just diffuse vessel disease, I would just focus on the right. I would leave the LAD, and I will try to treat the LAD medically, because I don't think you can fix it. The question also, what's happening with that bifurcation? You may want to salvage that diagonal. That diagonal seems to be more hopeful than this LAD. But again, going after that LAD and compromising more the diagonal without any good distal flow, I don't know.
But Ran, could it be that, remember, such a tight lesion in the left main to ostial LAD, and then whatever diagonal ramus or proximal serve? So maybe if you open at that area, and of course you cannot compromise any vessel. You have to have wire in the side branch. Make sure you're opening the side branch also, so that will we start seeing some blood flow in the apex. See, take the inverted mustache in the lower segment. So just by opening it, would you improve some blood flow and you start seeing the vessel? But yeah, the long term, no matter what we do acutely, the long term patency of this LAD is dismal.
Yeah,
Just,
Dr. Alfonso, go ahead.
Yeah, just for the sake of discussion, I mean, this is a terrible case. So it's severe left ventricular dysfunction, 15%, severe three vessel disease. I mean, it's full metal jacket in the LAD, in the right coronary artery, all these PCIs. So I don't think this is a case for CABG. I mean, I don't see the distal LAD. Circumflex is also very tiny. The posterior descending was not so bad. But I think the first thing we need to do in these cases is make sure what is the mechanism of mitral regurgitation and make sure that there is no CABG. I think there is no CABG in these cases, and then we need to proceed. And I think even though the LAD distal flow is very poor, or basically the vessel is occluded, I think you need to offer anything possible. And then I will use an impella, and I will go, I don't know, first perhaps the left main and then the right, or going to the right with the idea that this is going to be easier, and then you will address and tackle the left main with the open right. Perhaps this will be more secure.
Yeah, but this patient cannot have an impella, so you can use a balloon pump maybe, or you can use impella from the axillary, but I assume there is a disease as well there. So maybe we'll hear with Dr. Kearney. What would you do in Washington University?
Yeah, I think just to echo your comments that when the stented segment gets to the distal part of the vessel, those are the ones I'm not sure I can salvage. So I want heart failure to see them and look at that if that seems to be a big part of her presentation. But I think optimizing the circ and bailing out any of the side branches there would be kind of our biggest priority, just because I'm not sure about the durability of this and see what we can get. We've also, I think, scaled back quite a bit on our impella use in people who are pretty stable, but it's really hemodynamic dependent. I think whether to put a pump of some form in there. If all you have is a balloon pump, I am more likely to do that up front though, than kind of wait until they get sick.
Yeah, as we discuss this, I'm getting more convinced maybe to fix the left main into the circumflex. It may be one of the mechanisms for the MR, but this LAD is, as they say in Europe, kaput. But Brian, why don't you continue? We gave you a lot of the thoughts, and we have to make sure we on time.
Let's see what you did.
It's a great conversation because it's very similar to the one that we had. I think we felt that we had to offer something here. We felt that there was no CABG candidate with no distal vessel that we could see. We had a lot of debate with the apical LAD. Is it so diffusely diseased? Or is it just an inflow issue that's making the outflow look worse? And we went back and forth about which vessel to fix first. And we ultimately felt that, the RCA being a more straightforward lesion, we should try to fix that first and then try to tackle the LAD. So we brought her back. The LAD or the RCA was actually a fairly straightforward lesion to wire. So we wired and swapped out for a wiggle support and did an IVUS that showed it to be closer to a 4.0 vessel. And it actually gave fairly straightforward, which is balloon angioplasty. There was only one layer of stent in the RCA at that point. So we did elect to restent with a 4.0 onyx stent. I know that she had a recent 3.5 to the proximal RCA, but it looked like that was uncovered initially because there was only one layer that we saw on our IVUS interrogation. And so this is the result that we got in the RCA. And again, I know that's not the bifurcation lesion. It was the more straightforward one, but it's the one that we at least tackled first for her. And then I'll show IVUS pullback here of what we saw in the RCA after we stented.
Yeah, and there was a question from the chat about transplant. I don't think that this is a good candidate for transplant, given her age.
So we were happy with the result in the RCA, at least at this point. I know it's going dark here as we pull back into the guide. But we were happy with that. So then we moved on pretty quick to the bifurcation, which was the real complicated lesion to address here. So we went up and were actually able to wire the LAD pretty straightforward with a whisper wire, but the circ proved to be a very, very difficult wire job. And we actually were unable to wire it despite spending a long amount of time and a lot of wires. We started with a whisper, we tried a Mongo, a Pilot 200, a Fielder XT, and then eventually a Confianza Pro 12. But despite all of those, we weren't really able to wire the circ. And you see here's our Confianza, which is able to actually get somewhere, but it's clearly not actually in the stent or in the vessel itself. So I guess I'll pause at this point and ask the group, you know, in this situation, how do you guys proceed when you're at a tough bifurcation in stent and you can't really get one of the branches wired?
Dr. Sharma.
Yeah. So no, I think many times it will happen, and now you're trying to get a wire. Maybe it's not going exactly in the circumflex. So this concept that, you know, there is a subtotal, you have tried everything. I will still try to open the LAD and retry.
Yeah, so if you change the anatomy of the struts,
right,
you may create, remember, that's why we're doing POT. We're doing a lot of POT because we want to have a good access. So I wouldn't give away. I would agree with Dr. Sharma. I would try to at least change somewhat in the anatomy of the stents. But again, there is a risk, Dr. Sharma, that we're going to lose that circumflex if it can be completely occluded. My feeling is that the problem that you cannot cross is not because of a lesion, but because of the configuration of the metal. And again, I don't know what was the technique that was used before, culat, decay crash. I'm always worried about decay crash because they're Restenosis and they're hard to recross sometimes. But Dr. Alfonso, what would you do?
Yeah, I mean, if there is no other option, I mean, if it's impossible to cross the circ, then, well, somebody could say, well, in order to avoid complete blockage of the circ, an ablation technique in this case could, in theory, you know, there's no PO effect or whatever, but I don't know. I think I will go with a small balloon and try to change the anatomy of this bifurcation and try again before a final device in the LED. Try again the circ.
Brian.
Those are all great points, and it's ultimately what we decided to do. We decided to try to change the anatomy, knowing that, you know, if we balloon, maybe it makes it better, maybe it makes it worse, but we tried kind of everything we could think of and nothing was going. So we took a 2.5 balloon into the LAD and were not able to dilate it. Actually, there was a pretty big waist on it. And then so given that, we decided to do rotational atherectomy into the LAD because there was a non-expanding waist on our 2.5 balloon, which is clearly too small. So we took a 1.5 burr, did rota into the LAD, hoping it would allow our balloons to expand and maybe change the anatomy. And so after we did our atherectomy run, here's what we're left with. It's playing a little strange here.
Next picture.
So you start to lose some branches, but it could be also spasm.
But here's what we got after atherectomy. And you see that we're losing the circ with slow flow and, you know, it's getting worse. So any thoughts on how we would tackle this problem?
No, I think what you did now, earlier you could not open the lesion. Now go back with that balloon. Maybe I'll use a cutting balloon here at 3 or 3.5 and try to open, maximize, because we still have to work with that circ. Now, during this time, I know patient has no other hemodynamic support. What is the hemodynamics going on? How things are?
So we were actually a little surprised. She was tolerating this okay. We thought she'd get pretty sick as she was kind of hanging by threads in terms of coronaries before we even started. I don't know if it was maybe fixing the RCA that gave her some degree of tolerance to this, but she wasn't, you know, crumping, at least on us on the table. And we had some time to try some things and balloons and wires, at least at this point.
So I think then now you I would say that we go back and open that area once again, and then come back with a lot of people talk about the twin pass or bring a supercross 120 and just trying to make more focused entry of the circumflex. But now we have both decreased flow in the circ and also in the LEDs has opened a little bit, but now hopefully your balloon will open that up because you use a 1.5 bar.
Yeah, you want to salvage the circ if you can. So I think that I would try to rewire it again. I mean, maybe we will be lucky this time.
Okay, tell us what.
So those are all good points. And initially we tried to wire it. And again, we're getting outside the vessels here, outside the stent architecture. So we did exactly what you guys were talking about. We said we've wrote it. Maybe we can now actually expand some balloons and change the anatomy a bit. We took a 3.0 balloon and then ultimately a 3.5 Wolverine cutting balloon to try to make some fenestrations and flaps that would be amenable to us trying to get a wire down. And then we went back and you see there, it's not as good as it was in the beginning, but we got some flow back here.
We have a ghost vessel now. Yeah.
Exactly. And so we said, let's try some more wiring at this point and see what we're able to get down. And it took a good amount of time and a lot of wiring, but ultimately, eventually a Pilot 200 was able to get down into the circumflex.
Beautiful. Beautiful.
So we used our microcatheter to exchange for a workhorse wire. And then we're able to start doing some stuff here and we're kind of in business. So how would you guys tackle addressing this in-stent restenosis now that we're, an hour into the case and finally have a wire down the vessel?
Okay. So now we're going to the therapy. And I think, again, it's going to be a challenge to put here brachytherapy catheter. But again, those centers, they have it. I would still give it a chance because I think maybe now that you did a good dilation before it's restenosis again, that would be my first choice. My question to you, Dr. Alfonso, is drug-coated balloon. When you go through bifurcation, are you afraid that the coating will be shaved from the balloon?
Yeah, I mean, we always have this concern. I think, again, it's very important to dilate things properly, sometimes using a guide liner or extension catheter to make sure that you will be able to get as close to the lesion as possible. And in this situation, there is some controversy among the experts. Some people like to use, in this case, like 2 drug-coating balloons, like a kissing with that. Other experts, like Bruno Scheller, say that this should never be done. I don't know. I mean, one way or the other, I will use drug-coating balloons, plaquetaxial drug-coating balloon in the 2 vessels after the best dilatation I can do.
Dr. Kearney, would you go with the 3rd stent into the circumflex, given the fact that LAD is a lost cause anyway over time, and try just to salvage it with a good stenting left main into the circumflex, or you would do something else?
No, I think she's proven that more stents aren't the answer here. And in a lot of these cases, after the 3rd layer, it's like the last ditch effort. And without another parachute like transplant or something in her, I wouldn't entertain that. I think like you, it's worth a shot for these other alternative therapies.
Yeah, no, I agree with you. If there is one thing that I learned, more stents doesn't help. I mean, they actually... But the question again that I think is important before you start a case like that, Brian, is to understand what is the viability of that the anterior wall? Because if there is no viability, I wouldn't mind at all about that LAD and just focus. I would look at this. This is like a vessel that was grafted by Lima, or it's going to a dead tissue. There is no point to fight on the LAD. The circumflex, however, seems to be more worth fighting, but a functionality test would help. One comment on the balloon pump impella. I'm always amazed how many patients who have chronic ischemia or chronic disease tolerate well the procedures. Sometimes with a little bit help of levo, norepi, but most of them, they do not need any support. I mean, the question is, we usually get in trouble in patients that are not used to that kind of an ischemia. And also one thing that can help you, if you would have done a right heart cath, or if you had the LVEDP on this patient, if it's a low LVEDP, I think it's going to be, again, more forgiven than very high LVEDP. But we have more questions from the chat. So, John, do you want to tell us what the questions are?
But you had the LVEDP. LVEDP was quite high. Your wedge pressure was 30, right?
Yeah, it was in the mid-20s. I believe that was, a Thursday or something like that. And we let her get tuned up by heart failure and then brought her back early the next week to do the procedure. And I'll be honest, I don't remember off the top of my head if we dropped into the ventricle. I would be
So you
surprised
did a
if we did.
ventriculogram. No, you did the ventriculogram. No, you had the ventriculogram here.
John, any questions?
Oh,
on
yeah.
that?
Yeah, there is a delay. Yeah, Dr. Sharma, so that ventriculogram is from about a week earlier. So I think that is one of the questions that we have here is just from a clinical judgment standpoint. This was an outpatient that presented with subacutely worsening symptoms and then has right heart cath consistent with cardiogenic shock. Is this a case that anyone on the panel would do right then, or would you admit the patient and optimize them and then evaluate for mechanical support options? And then the second question is, one from the panelists was imaging performed? And I know Brian showed that one IVUS run that showed a combination of stent under expansion and neoatherosclerosis. So could the comment panel at your institution, what imaging modality are you choosing to use to assess the mechanism of ISR, be it IVUS, high definition IVUS, or OCT?
Well, I think all of them as good as they get you the answer. And I think that, again, OCT may give you a little bit more information. Left main OCT is a little bit more problematic, but osteal lesions are problematic. But I think, again, do whatever you do, and you can get the catheter in, and the image will give you enough answer in terms of the mechanism. Is it tissue? Is it mechanical? Is it under expansion, et cetera, et cetera? So that's what I would do for the imaging. With respect to treatment, any vessel during the shock, again, I will refer to Dr. Sharma. What would you do when you have the patient in shock? This is not an acute MI. I mean, this is a kind of progression of disease, probably of ISR. I didn't see any clots here. Would you intervene at the time of the shock in any of the branches?
Yeah. So I think that's, as I mentioned earlier, that the culprit vessel concept of the shock, I think that probably is for more so is a truly STEMI type of patient, has total occlusion of the one vessel. Now you're going after 80-90% vessel and creating some extra injury, and that has been harmful. So this kind of case where there is no true culprit vessel, could be more than one, I would probably do both at the same sitting. I know that there was no impella, but whether can put a balloon pump, sometimes that is possible. And if there is a chance for optimization, we think that patient is not that sick, knowing that, biggest problem with the cardiogenic shock will be that you have to do some antegrade blood flow to stabilize the condition. We can give pressures, we can give diuretic, but some antegrade blood flow, if truly cardiogenic shock, even in the chronic cardiogenic shock, it's not an acute, which you're feeling, that you need to optimize medical therapy. In acute, you definitely, that some blood flow restoration will be required. Now, if doing RCA gets a little bit of better hemodynamic, probably okay. Let's bring the left system a little later. There's nothing wrong because, as you saw, I'm sure it took a few hours on the left side. More VR, more procedural, all that dye, all basically trauma to the vessel, that continues to create more trouble. But yes, goal should be that we are coming out here without putting any additional stent, particularly on the left side, maybe some focal area, which we need to do, but otherwise, and then can you use a drug-coated balloon or not in America, but outside, yes.
So we're coming to the end of the hour. I just like every one of you to say in 15 seconds, what is the lessons that you take from this session, bifurcation, in-stent restenosis? I'm going to start with Dr. Alfonso.
I see.
Well,
15
very
seconds.
quickly, I mean, this is not an easy pathology to treat. In America, you got this 10%, in Europe, we got 5% of our procedures. These are unique extreme cases, even though with all the knowledge and all the armamentarium, sometimes they keep coming back, and we need to keep learning.
Thank you. Dr. Sharma?
I would say that I know people are worried about rotational atherectomy. Both those cases of Kathleen and Brian, I would have start with an atherectomy, which I said before, during the case, ultimately ended up in using this LED anyway. So key is that, yes, appropriately. Now, I would say that if you can get IVL balloon, there's no question you avoid the atherectomy. But if you know that IVL balloon will not go and do the job, atherectomy plus minus IVL.
Kathleen?
Yeah, I think both of these highlight how the tools we have are more effective with fewer layers of stent, not more. And so I think really focusing on using that the first time the patient presents with ISR, which you didn't have the opportunity here, but I think we can get much more effective and durable results.
John Lisco?
Thanks, Dr. Waxman. I think one of the things that I've taken out looking at all these cases that you see some world-class operators with the best tools available, still struggling to get great results and still having a lot of questions. So I think on the index PCI, having a meticulous result and focusing on imaging and doing it right the first time so that you don't have to run into the problem is my take home.
Thank you. And I'm going to hand to Dr. Raab to finalize and summarize the session.
Thank you very much. Thank you very much for the panel and the case presenters. Great cases. This is a vexing problem. We may not have all the solutions, but one thing about bifurcations, know your techniques and do it right, and don't avoid the steps, okay? And use imaging efficiently. And I think I cannot say more than that, that imaging is key in the first intervention for bifurcation. It's key. Do the steps right if you're doing two-stent technique. Don't skip any layers. You've got to do it right. If you do it right, the chance of the patient coming back is low. I mean, obviously, in both these cases, we didn't know what kind of technology or technique was used, and maybe the operators did not follow what we would currently do in practice of bifurcation stenting. But the question for all of you is this: with Brian's case, what would you do if this patient came back? What do you do again? I mean, what do you do with this patient? And that's the question that's hung over me since Brian presented this case. Any one of you?
Well, if you ask me, I would do brachytherapy to the limb, to the circumflex. I would do actually, I won't wait until it restenosis. I will call the patient in another session, maybe a week after the recanalization, let him rest, enjoy a little bit perfusion, do a brachytherapy, at least to the left main, to the circumflex. I don't mind to do bifurcation to the LAD if this helps. I don't think there is anything to lose there. With respect to the right, we can give a chance. It's the first DES, second DES. But I think you're not done yet, because if you're not going to do anything, I guarantee you're going to see that patient coming back with even more severe restenosis.
Well, thank you, everybody, for a delightful session. It's really very, very good. And I hope it helps our audience in these tough cases, which are really difficult to evaluate and take care of, even by experts. We all have different opinions, but these are really very tough cases. Thank you very much for participating.
Bye-bye.
Thanks for having us.
Thank you.